Good afternoon and welcome to Health Matters. This is our weekly discussion with some of our health experts and bringing healthcare that matters most to you and to your family. My name is Julie Kentville. I am president of the McGill University Health Center Foundation, and I have the honor of being your host today. My guests have extremely long lists of achievements and accomplishments, awards, and publications, so I'll try to keep it brief. Dr. Don Sheppard is director of MI4. He is professor and chairman of the Department of Microbiology and Immunology at McGill University. Dr. Marcel Behr, he is co-director of MI4. He's a McGill professor and he's founding director of the McGill International TB Center. Thank you both for joining us today.
Thank you.
Now, both of you are truly on the front lines of the battle against COVID. You are leading the Canadian battle to find a cure, and you're also treating patients at the MUHC. Can you take us behind the scenes and give us a sense of what a day looks like on the COVID units? And maybe I'll start with you, Don.
So it's an early morning start because we have to be in and let our poor night resident who's been there all night get home. We then look at what's happened over the course of the evening, sign them out, sit down with the nurses, find out what the active issues are for the day, and then we have to gown and dress up. So we put on scrubs, we get rid of all our street clothes, we put on PPE, which in our case means the gowns, the gloves, the mask. There, Marcel's doing a demo for us. He's perfectly prepared. We have the face shields that go on, and from that moment on, you are wearing the spaceman outfit for the rest of the day, regardless of the temperature in the rooms. And then we go from room to room to visit our patients who've been in essentially solitary confinement in their isolation rooms since they've been admitted to the hospital with COVID. And you'd think that most of our day is spent doing medical things. And indeed, we have, patients that are like the 45-year-old gentleman I met the very first time I went on the COVID ward. He had been healthy, working at his job at a bank. His mother, however, had been a healthcare worker at a long-term care facility. She got the sniffles. He got COVID from her. And when he got sick, he got very sick. He came to our emergency room short of breath, coughing, was admitted up to the ward, and within about 12 hours, his little bit of oxygen that we had him on had gotten to the point where we couldn't give him enough oxygen on the floor. He had to go to the ICU, eventually had to be intubated, put on a breathing machine or a ventilator, only for 48 hours. After 48 hours, he turned around. He was extubated. They took the tube out, took him off the machine, sent him to the floor, and we were all ready to send him out. But the night he arrived on our floor, he suddenly started complaining of chest pain and trouble breathing again. And we now know that one of the main complications we see in coronavirus disease is actually clots in the lung. And we did a CAT scan for this gentleman at about 11 o'clock at night, and sure enough, his lungs were now full of clots. Essentially, imagine your blood sludging in your lungs. So you can get air in, but that air can't be transferred to your bloodstream to get to the rest of your body. So we had to put him on blood thinners, what we call anticoagulants, and deal with a whole new complicating problem that kept him with us for another week. But it's got a happy ending. At the end of all of that, he went home on one pill more than he came to us. He, of course, came to us with no medications, and he is home safe and well, and what we would consider a medical victory. And the reason that we need the ICU capacity and the medical capacity to help people over this dangerous period and get them back to where they go. But that's just the tip of the iceberg, the sort of the really hardcore medical part of it. And maybe I'll hand it over to Marcel, and he can tell you what we actually do with most of our patients.
Yeah. So as Don said, there are people who have a COVID pneumonia, but there's a lot of people who've been indirectly affected by COVID. People who are in a senior residence that is struck by COVID and they're short-staffed and they don't have enough hot rooms for the people with COVID. So people are transferred over for a variety of reasons, decompensation, they may not have actually been getting the appropriate level of care, or some other disease they have may have become unbalanced. So as one example, one of the patients I had on the COVID ward had multiple sclerosis and was stable in a kind of a protected setting, but she had an adapted scooter and she was able to drive around. But the COVID illness she had was like a cold, but then 5 days later, her multiple sclerosis exacerbated, and then no longer was she as autonomous as she was before. So in such cases, a lot of what we do is go into the room and talk to people and listen to their concerns. We have this incredible capacity to buffer the COVID epidemic in Quebec by transferring patients from hospital to hospital, but that comes at the expense that people end up in a hospital where they don't know anybody. They don't know the doctors, they don't know the nurse, they don't know the clinic staff. And simply going in and spending time and asking, where are you from, where are you followed, who is your normal doctor, then calling that doctor, finding out more about the case, and then going back the next day and saying, I spoke to your doctor says this is what's going to happen, I'm very encouraged about it. These are the things we can do. And another patient just reminds me of when people are getting better. One of the great signs I had was when we ran out of medical concerns, I sat down and I said, is there anything else we can do? And he said, I want the controller of the TV to work. And that's a sign of agency. That's a sign that somebody's taking control of his room. And I think in an ordinary situation, we would say, well, that's not a medical issue. That's not my problem. But in fact, now it is my problem. And I do go to the nursing station. I do go to the report and say, can we ensure that this man, when he's up, gets to watch the TV he wants to watch? That's one of the few things he has control of, and we should foster that.
So 3 years ago, together, we launched MI4, and this was thanks to an unprecedented commitment by the MUHC Foundation and McGill University to invest $120 million. And I want to thank you both for your leadership. And I also want to take the opportunity to thank the late Elspeth McConnell and her Doggone Foundation. And I believe that the executive director of that foundation, Paul Marchand, is listening to us today. Thank you so much, Paul, because without your leadership, we would never have been able to launch MI4. Now, this was an objective to build the very first institute in the world. We're still working towards that for infectious and immune diseases. With all the work that you did and with the incredible consortium of researchers that you've built in Montreal, Marcel, did we ever anticipate having a pandemic in this decade?
I think, Julie, we did anticipate a pandemic. Many of us went into infectious diseases because between the time of our childhood, the time of our university, the time that we went to medical school, there was always something new. There was almost every year a new disease. Just in the last 20 years, there's been SARS, and then there was the H1N1 influenza, and then there was the Middle East Respiratory Syndrome, which is now called MERS. There was the major Ebola outbreak in West Africa. So I think we've always been concerned there would be another epidemic or pandemic. We didn't know it was going to be this year, this month. We didn't know what it was going to be called. So we weren't prepared down to that level of detail, but we did expect something to happen. And it did happen. We may have been imperfectly prepared. We foresaw it, but there is always something new about every epidemic, and it confronts us, and it makes us think hard and be creative and move on our feet.
Don, you have predicted a pandemic every decade thanks to globalization. What are some of the key learnings from this current pandemic that we can plan for the next one?
Yeah, I think we learned some very valuable lessons here in Quebec about our healthcare systems. One of the most important ones that became quite obvious quite early on was that we need supply chains for the tools just to do our daily work. When we think about doing viral testing, that viral testing needs a swab. It's that unpleasant thing we stick way back in your nose that you think is coming out the back of your head. It's in there so far. Well, did you know that most of those are made in northern Italy? So as you can imagine, when the outbreak hit in northern Italy first and then came to us, suddenly we couldn't get swabs to do the viral testing, and there was a shortage of swabs. When we do those tests, we use chemicals or reagents that are enzymes that are made in specialized factories, and those factories are used to making a certain amount per year in a global market. Well, South Korea dealt with their coronavirus outbreak by doing massive countrywide testing and sucked up all of those reagents that the entire world needed. So there wasn't any when our outbreak came. And you heard in Quebec, in Ontario, in the US, ramping up testing became almost impossible because there was no supply chain. And when we talk a bit about one of the things that MI4 worked on, we can tell you a little bit about how we're trying to solve some of those supply chain issues with made in Canada, homegrown solutions. I think the other really important thing we learned was about our healthcare institutions and the way that we lay them out, in particular with respect to long-term care. I don't think we really predicted that the outbreak in Montreal and Quebec would actually be driven in large part by the long-term care facilities. We all knew that elderly patients were at risk, but I don't think we had the perception that they could not just be at risk for bad outcomes, but could actually be the driver of disease that then came out of the long-term care facilities through healthcare workers and into the community. And with the way that the system was organized, we had physicians and workers going into those facilities and going from facility to facility to facility as kind of part-term workers or dépanneur workers. And of course, those healthcare workers became opportunities for the virus to hop from institution to institution. And it's not someone that anyone had ever sat down and thought of before, but we are now acutely aware of that flaw in our system.
Thank you. Marcel, how is Montreal contributing? How is MI4 and how is Montreal contributing to finding a cure and getting a better understanding of this virus?
So generally as clinician scientists, Shirley, we sort of, Dawn and I think of what are the solutions out there that we can push out there and what are the knowledge gaps where we have to foster research. And there is no known cure for COVID-19. And there currently is no vaccine. So there are a lot of stopgap measures we can support right away, which is repurposing existing drugs and trying them out. But we really feel we had to get to the bottom of it and provide the research infrastructure so that if people want to look for new drugs, if people want to look for new vaccines, the capacity would be there. So one of the first things we did is we set up the level 3 biosafety lab, which was a tuberculosis lab, to be a SARS-CoV-2 lab, to have the safe handling of the virus that is causing the pandemic to enable other researchers around the hospital, around McGill University community to do research to look for new drugs and vaccines. So our level 3 lab is now certified by Public Health Agency of Canada, is growing the virus. With the support of Chen Lang, who's a virologist from the Jewish General Hospital, we have the viral culture going. With the support of Maz Divangahi, who's a pulmonary immunologist here at the MUHC, we have validated models now of infection, and that then allowed us to underwrite 27 grants to the CIHR where different investigators from around Montreal came to us and said, I want to work with the virus and do the following experiment and look for the drug or look for the vaccine. And we could say, go for it. We will provide you the capacity. And the same way that we have the capacity in the level 3 lab to enable people to work with the virus, MI4 helped develop other capacity to do clinical trials, to take the things that already exist, things like hydroxychloroquine, and rather than just pushing them to patients saying, hey, this is an opportunity to test them, to investigate them, to find out if they do work, and to find out if they don't work, to find out if we would end up on the Trump side or the Fauci side of these kind of global debates. And we are contributing to these global debates where MI4 funded projects through the MI4 funded clinical research program are coming out and publishing, for instance, that hydroxychloroquine does not seem to prevent COVID, and there are ongoing trials, the CATCO trial, there's a plasma trial. These are led by Dr. Chang, Dr. Semret, who are colleagues of ours, that are then allowing us to go forward and find out what does work and what doesn't work so that we can move on to the next thing. The other platforms we're supporting are biobanking initiatives to put away samples so we can learn more for later. And people who we're working with are also part of this Canadian Immunity Task Force to try to determine what % of people have been exposed and are protected. Dawn, anything else to add here?
So I think Marcel's given you a good feel for how we, if you will, built the bones that allowed people to do the research. But our mandate is not just to provide services, we also want to spark ingenuity, innovation, and creativity. So very early on, when we saw the writing on the wall that there was going to be a pandemic, that it was coming to Montreal, that it was going to be a real thing here, we actually, with the support of the MUHC Foundation and some critical donors, the Dogon Foundation that was already mentioned, the Hewitt Family Foundation, and the Trottier Family Foundation, launched what we called our Emergency Coronavirus Research Fund. And this was initially a $4 million fund to support immediate projects that were going to have immediate deliverables on a maximum 6-month time frame. And before the outbreak was in full swing, we had 48 funded projects led by researchers across McGill, Montreal, Canada, and internationally, looking for a wide range of topics, from looking at new drugs, looking at clinical trials, such as Marcel has already told you, looking at testing strategies, and moving out of the sort of medical space into what about the countermeasures? What are the effects of social distancing? What are the effects of locking down? Looking at mental health, ethical issues, legal issues, all of the sort of spin-offs that this outbreak has done to our real lives outside of the hospital. So I can give you a couple of examples of the ones that I'm the most happy with. I alluded to the testing reagents before, the enzymes that we need to detect a virus from a swab, and how we were running out of them in Canada. Well, we had some researchers at the MUHC and downtown McGill campus who realized that what they do in their day-to-day life is make proteins, which are the things that you use in these kits. They do it for a different reason, but they got really good at it. And they said, hey, I think we could actually do this. So with seed funding from us, with support of the MUHC, they actually went out and built the capacity to make a made in Canada, sourced here, own version of the tests that we use to diagnose coronavirus. They've now partnered with the National Research Council of Canada and funding from ICID, the Ministry of Industry Canada-wide, and they're going to be able to roll out enough of this stuff to test the entire country and to absorb the capacity we need in the dreaded event that we have a second wave, or indeed any other virus that comes along. And we don't have to worry about somebody close the border and saying they're not going to ship those supplies across and they're going to keep them there. We don't have to worry about what Trump is up to with respect to international trade. We just have to get the stuff from Montreal to Ottawa down the highway. And that, I think, is a really impressive thing. The other one that Marcel mentioned was the clinical trials platform and the hydroxychloroquine trial. That is a really nice one, I think, because it not only answers the question of, does hydroxychloroquine work to prevent disease if you're exposed? And if you didn't catch it, the answer is no. But because we did this study of people that were exposed, we also had the opportunity to add new trials onto people who were exposed to coronavirus. And there's an ongoing trial that I think is going to be really helpful for healthcare workers that tests people to look for the virus while they're on isolation after 7 days, 11 days, and 14 days. Because right now, if you're exposed to the virus and you're a healthcare worker, you're at home for 14 days and you can't work. And if you can't work, you're not contributing. And most of us hate that. What if we could do the viral test at day 8? And at day 8, if it's negative, that predicts you're good. You can go back to work. We know that you have virus before you have symptoms, so we should be able to test early. And if we can figure out that window, we can get people off isolation a lot earlier than 14 days.
John, just as a follow-up, we've had a question from one of our guests about the plasma trial, which I'm happy to say is now being supported by Power Corporation of Canada. Don, can you tell us a little bit about what we're doing on plasma?
Sure. So we are part of this large-scale international plasma transfer study. And for those of you that don't know the details, it's actually a very simple concept. We know that one of the ways our body fights off the virus once we are infected is we make these little proteins called antibodies. And antibodies can neutralize the virus in our own bodies. Now, you and I, if we've never been exposed, we don't have any antibodies. But if you've just gotten over coronavirus and you no longer have the virus in your body, you have buckets of these antibodies floating around in your bloodstream. So what we can do is take part of your blood, the plasma, the part that doesn't have red cells in it, so it's nice and clear and safe, and we can actually then give that as essentially a transfusion of immunity to a patient that doesn't have antibodies. And the trial is a single dose of plasma from someone who does have antibodies to someone that doesn't have antibodies, and it's for sick hospitalized patients. I'm actually pleased to say that the first patient who was enrolled here at the MUHC, the first adult patient in Montreal, in fact, was when I was on the ward. So it was really cool to see it actually going into the real world. And it kind of highlights a point that we didn't bring up, but I guess we should have when we talked about the clinical trials platform. One of the ethos behind the clinical trials platform is when we're in a world where there's no cure and there's 50 possible cures, we feel that we owe it to our patients to have access to as many of these options as possible. And that every patient who's at the MUHC or the JGH should have the ability to enroll in a clinical trial. And that's part of our job as clinician scientists, is to bring these options to our patients.
Thank you, Don. Marcel, we're hearing about a lot of asymptomatic people. So they are not suffering very much from COVID, but yet we're hearing, and we just heard from Don about a 45-year-old patient at the MUHC who had severe COVID. Do we have a sense of who is most at risk of having severe COVID?
Yeah, so Julie, effectively, the world estimates are there's maybe 7 million people who have been infected so far. Maybe it's more than that. And it really depends on whether you ask what percent of people who are infected are going on to severe disease, what percent of people who are sick go on to severe disease, because there's a number of people who are either asymptomatic, they were never symptomatic, or they're pre-symptomatic. They're not symptomatic today, but maybe they're a little bit tomorrow. Overall, the global estimates seem to say that maybe about 1% fatality worldwide of the people who are infected. But as Don mentioned before, it really depends on where you hit. If the infection goes through senior residences and people are over 80, then the risk is much greater. If the infection goes through schools, or if it goes through an aircraft carrier in the US of young, healthy people, then the risk of severe effects and fatality goes down. Generally, the things that are tracking the most with severe infections are age, cardiovascular disease, diabetes, pre-existing lung disease. And really the highest rates of severe disease are over age 80.
So existing immune diseases or cancer treatment, bone marrow transplant, kidney, does that increase your risk of having severe COVID?
For each of these different diseases, it has to be worked out individually. So it would be simpler to say there are the healthy people and the immune compromised people, and the immune compromised people do better or worse. But in fact, we don't know if HIV infection makes it worse or HIV infection makes it better. And if you're dealing with a 1% event, you really need to study something 1,000 people like that to start to know if something's going to happen more than 10 times or less than 10 times. So there are, for instance, studies out of New York City where there are large cohorts of IBD patients, people with inflammatory bowel disease, that's Crohn's disease or ulcerative colitis. And in those studies out of New York City, they said the outcomes were more or less normal. They were no worse, they were no better. But you can't take that result and say, therefore people with multiple sclerosis will do well, or therefore people with cancer will do well. For each disease group or patient group, you need to have new data on that. And I think it's kind of emerging right now. I saw on Twitter yesterday that people are looking at whether people who've had tuberculosis are doing differently with COVID. So I suppose that the literature is really coming on every type of patient population.
Don, can you give us an idea of when we might see a vaccine? Do you think we're going to see one within the next year?
I'll come back to that, but I just want to add one little point to what Marcel was saying, because I can't resist a little plug for an exciting program that's going on that is one of the MI4 programs. So if you remember, I started telling you about a young man that had severe disease. So that young man was obviously not elderly, had no heart disease, had no diabetes, had no pre-existing lung, I can go on here. There was no reason why he should obviously get sick. And his mother, who was the one who was really exposed, had nothing, essentially no symptoms. So we know there is a small group of people that we don't understand why they get severe disease. And so one of our investigators here at the MUHC, Dr. Don Vin, has actually been collecting these cases as part of a large international consortium that reaches into Europe and North America to try and figure out why there are these people that get much more severe and often lethal disease that you would not predict do. And they're doing a very deep dive into the genetics, into the immune system, into the bacteria that live in their stool to see if there is some reason why these people get sick. And they've already found a number of leads that they're exploring, suggesting that their immune systems might be different than the rest of us. And there may be clues as to how to prevent severe disease across the board if we look at these exceptions, because sometimes the exceptions prove the rule. So that said, you asked me about a vaccine. And everybody wants the crystal ball answer of when's the vaccine coming? Is it going to be safe? And am I going to get it? And will it be the Chinese vaccine or the British vaccine or the other vaccines? So what can I tell you about vaccines? I can tell you there are 10 vaccines in clinical trials right now. And by clinical trials, I mean they're in humans. The ones that are in development pre-human number in the over 100, just to give you an idea of how much work is going on in this space. The vaccines that are in humans are everything from killed virus to small pieces of the virus to even some very fancy DNA vaccines where the genetic code for the virus is injected and your own body makes the proteins of the virus that you then react to. And all of these are in clinical trials right now. So the process has started, but clinical trial to human is actually normally quite a long path. And the reason in this case is actually less about getting a vaccine that works, but more about getting a vaccine that's safe. So let's just stop and think about the numbers for a second. Let's say that we want to give this vaccine to everybody on Earth who's at risk, who hasn't had it, and conservatively, let's say 4 billion people need this vaccine. Well, the vast majority of those 4 billion people are not at risk of dying of coronavirus. In fact, most of them have zero or near zero risk because they're young. It's only the elderly population that has a significant risk of severe outcomes or dying. So right away, we have two groups of people. People who are getting the vaccine essentially for everyone else, and people who are getting the vaccine for themselves. Now, if you take a vaccine that has any risk, let's say it's 1 in 1,000, 1 in 100,000. If your chance of dying of coronavirus is 10%, and I tell you there's a 1 in 100,000 risk of the vaccine having a side effect, you don't have a problem with that. If I tell you you're taking the vaccine, which has a 1 in 100,000 chance of something bad happening, but you're doing it for everybody else, and it's not actually going to benefit you personally all that much, that's a very different value proposition. So for those two populations, we have to really understand the side effects, and we have to understand the rare side effects, which by definition means doing these trials in large numbers of people. I can't tell you if a side effect occurs 1 in 1,000 patients if I only test 100 patients. And similarly, 1 in 1,000, 1 in 10,000, if I only do 1 in 1,000. This is the big numbers that we have to think about when we start to think about worldwide vaccination. So if I put on the pointy hat and stare into the fuzzy ball and try and come up with a date, I think what most people say is it will not be until 2021 before there are vaccines going into people that are not part of clinical trials.
Marcel, in the absence of an immediate vaccine, we've heard a lot about the benefits of herd immunity. Can you tell us a little bit about that and when we might see a test here in Montreal?
So the concept of herd immunity is if we had not shut down and we went through our lives and everybody was infecting 2 to 3 other people, we would have needed something 60% of us or so to be immune for things to slow down. There is not very good evidence right now that Canada has 60% immune. That would be herd immunity. But what we need to do is we need to do serology studies. So the Canadian Immunity Task Force that Tim Evans at McGill University is leading is about to launch a 40,000 person study across Canada using AMA Quebec and Canadian Blood Services and other resources to find out what % of people are immune in Canada. There have been studies in some places, like in Switzerland, where some cantons, maybe 5 to 10% of people are immune. There have been some studies in healthcare workers in London suggesting maybe 40%, or if you are on one of those cruise ships that was described, maybe 40% of the people on that cruise ship were immune. But we're probably much lower than that. And despite the large number of cases we've experienced here in Montreal, we're probably well below, somewhere below 10% who are immune right now. So we do not have herd immunity, and we cannot just sort of say, oh, well, we'll just open the doors and hope that things will take care of themselves. I don't think we're there, but we're going to need to have much more results on that. And that's when you look at the population level, what % of people in Montreal, 1% of healthcare workers. At the individual level, I can tell you there's a lot of people who want to know, am I immune? And people who say, when is there going to be a testing? Can I be tested? And there's a variety of different reasons people ask me. Some say, I bet you that thing I had in February was really COVID, and I'd like to know, because if I really had COVID, then I don't have to worry about it again. I also have people coming to me and saying, I did have PCR positive COVID. Can I donate my blood to be a control for the lab to make sure it can detect it? And so a lot of people want to know, when is our hospital going to be offering a COVID serology test that I can order as a doctor for you? And there's a little problem with that. Assuming we have a test and it could be available in a month, and assuming we have the platform and we work it out through the test center how to do it, I'm not quite sure what I would do with that result. So let's say I tell you, Julie, on July 5th that you have antibodies to COVID. How can you use that information in October if the second wave hits? How can you use that information next December to decide whether to go to Florida or not for the winter break? So just because at a point of time you have antibodies doesn't necessarily mean you can use that to make plans for your summer vacation, for the school return, all the things going forward. So there's a lot we still need to know about immunity. And the first step is having the tests. But beyond that, we have to know what to do with the tests and what they predict. And so right now we have, fortunately, a lot of partnerships. We have some MI4 funded grants that are looking at the details and the kind of tests that we need to develop.
But Marcel, do we know yet if we can catch it a second time and how long that immunity might last? So if I've had it, can I catch it again in 6 months?
Yeah, so without knowing about whether it's antibodies or cells or other types of protection, we do know epidemiologically that there's been about 3.5 million people worldwide who have had COVID-19 who have recovered, and there are so far 0 documented cases of somebody getting it again. And by getting it again, it would mean you went to negative, and then you were documented to have positive, and it was a different strain, that you were re-exposed and reinfected. So far, as I read it, that has not yet been reported. So that means for those 3.5 million people who've recovered who didn't get it again, they were protected for what, 3 months, maybe 4 months. So we know that it seems to be protective for 3 months. We don't know if it's protective for 3 years or for 3 decades, and we don't know the durability of it. Let's say the protection goes down over time. Does that mean it's an on-off switch where you're protected and then one day you wake up not protected, or does it become 80% protected, 60% protected, 40%? It's more likely that it wanes. And we need more time to follow the epidemic to learn what is the time course of this protection.
So Don, I'm going to hand it over to you now. We won't have a vaccine tomorrow. We're beginning to deconfine. I think we've reached the maximum duration of our capacity to be in confinement. What does this new normal living with COVID look like, and how do we stay protected?
So yes, our new normal is kind of a 2-phase new normal, right? We're all talking about BV and AV, before vaccine and after vaccine. That's kind of how many of us are starting to frame this. And I've had an eye on some of the chats as they've come through, and they all seem to be framing around, what do I do until, what do I do after, when is the switch gonna happen? So let's just focus on the BV, the before vaccine period. So this is the limbo. This is the place we all hate to be because the answers are not clear and everything is about relative risk and balancing risk benefit. There are not going to be black and white answers. Nobody is going to be able to tell you, you are 100% protected if you do X and you will get COVID if you do Y, because we've got a shifting backdrop of the virus in our community. Right now, the cases are plummeting and they're going down, but will they peak? We've seen in other places, in Iran right now, they are already having a rebound wave that when it never disappeared, it never got to 0 and it came back. Whereas places like New Zealand, they have eradicated the virus. Unfortunately, Canada is not quite as easy to isolate as New Zealand is, so I'm not sure we're ever going to get quite to the level of eradicating the virus like they have. So how do we live in this world? And I think what we have to do is we actually have to make some personal risk-benefit decisions. And the risk-benefit decisions have to be informed by our own personal risk. So you have to recognize, are you someone that is at risk of developing disease and having a severe outcome? And are you at risk of being a spreader? Are you in contact with people who are themselves at risk? And can you modify your contact with them? So the obvious example is if you have an elderly parent living at home, even if you're 18 and you're not personally at risk for a bad outcome, you have to take into account that your actions have knock-on effects with those people. So I think we want to prioritize the activities that we think are safe. And let me be a little bit bold and say, I think that outdoor is better than indoor. I think the vast, vast majority of transmission events that I have read about, that I have seen, that have been documented are indoor transmission events. I do not think that having someone pass you too close on the sidewalk as you're walking down NDG is likely to give you COVID, and you don't have to stress too much about that. I'm not so worried about the 3 teenagers less than 2 meters apart on a blanket in Murray Hill Park. I don't really think the kids racing past each other playing soccer are going to spew virus into each other. I think that the place you need to worry about transmission events are indoor activities with prolonged exposures. And by that, I mean usually more than 10 to 15, let's say, minutes. That's when you are at risk. So we need to look at our lifestyle and see how can we modify our lifestyle to avoid those situations. And we're lucky that summer is coming and we will have a break where we can use our outdoor activities a little bit more. It's going to be more challenging if this continues on to January, when Montreal outdoors is slightly less encouraging for us to do activity. From a systems point of view, there's also going to have to be some changes. We are going to have to be much more aggressive with our test and trace. And what do I mean by that? So it's not just about testing and finding the new cases. We have to learn from successes in public health in the past, how we eliminated diseases like polio and smallpox, and we're going to have to do what we call ring testing. So Julie, you are unfortunate enough to get coughed on when you were at the hospital one day working hard to support us, and you get COVID, and then you test positive. We now need to find out every person that you've been in contact with in the next 14 days and test all of them, because some of them may already be new cases, asymptomatic shedders. And then we need to do all of their contacts until we run out of positives, until every one of those rings is a person surrounded by only negatives. And every one of those people has to go on isolation, and every one of those people becomes a new case. That's the sort of expanded testing strategy that we're going to have to work with if we want to protect people going forward.
Doesn't sound, Don, that you are promoting the old-fashioned chickenpox parties.
I feel like there's a very big difference. When we had chickenpox parties, we had a disease that had very low mortality in children, very high mortality in adults, which is similar, but the difference is we had nothing on the horizon that was suggesting that a life-saving vaccine would be available in less than 18 months. That's a very different situation than where we are today. That said, you could argue that our summer daycares and back to schools are effectively, in some ways, the equivalent of the chickenpox parties. And it will behoove us to be careful that those kids going to daycares or back to school are in their own little bubble where they are isolated, or their parents are isolated from the particularly high-risk individuals.
Marcel, we'd love to learn from you. Now, you have 4 children, you work in a hospital, and so does your wife. How do you stay protected, and how do you protect your family?
So largely, we consider our home as a bubble. And within the home, you know, the kids are all at home right now. They're all taking classes by Zoom. Sometimes the elders supervise the younger ones, and sometimes the younger ones just simply play video games. And we would like them to get out more. We'd like them to do a little bit more and maybe play a little bit at the park. But generally speaking, the home is a bubble, and we've all been there for 8 weeks or so. So we think it's a very safe place. Like Dawn and like my wife, we then leave that bubble, and every day you go to work, you actually have to ask yourself, what am I doing, where am I going, and how can I do it safely? Fortunately, I can do it by walking outdoors. When I come into work, I feel very safe. I wear a mask as soon as I come into work, and I only take it off when I come out of the elevator into my own office. When I'm on the ward, I have the PP, and the hospital's been fantastic in providing that when people are on the COVID wards, they are safe and protected. And to my knowledge, nobody has gotten COVID working on the COVID wards. So then the only other thing that happens is, like many people who are listening, our families are more complicated. So you can have the bubble, which is at home, but then you say, well, what about my mother who's in a senior residence? Am I allowed to see her? And the answer is no. I'm not allowed in there. And I know that the people in the senior residence, some of whom may be listening in, are afraid of me because I'm an infectious diseases doctor. Trust me, I'm pretty safe because I am wearing PPE, but it's worth just noting that we've relaxed things a little bit where my mother's allowed to come out of the residence and meet us in the park. So as Dawn was saying, outdoor activities are okay. We stay 6 feet apart, we walk in the park, we wear masks. So the risk of transmission is very low. But I'm sure my mother is not alone in experiencing that some of the activities of daily living are a little bit more complicated than they were before. So fixing her phone or changing the batteries on her hearing aids, things that used to be just simple tasks, you would just pop up to the room, take out the battery, swap it out, and I'm not allowed to do that. I'm not allowed to go in there. And I think all of us are hoping there's going to be ways we can simplify those little parts of the lives. But we also want to respect that where there are congregate settings, like senior residences, we don't want to run the risk, because really what our actions are, as Dawn was saying, is not what can I do to prevent myself from getting infected, but it is what can I do today to prevent myself from unwittingly spreading an infection that I didn't know I had today.
And Marcel, the question I get most frequently is, do I have to wait until the vaccine is in place before I can hug my grandchildren again? How do you respond to that?
For now, the answer is probably yes. The only other way around it is, depends of course on where you're living. You can actually move into your grandchildren's home and quarantine yourself for 14 days. And then if everybody is fine for 14 days, that could become your new normal. And then you could actually cuddle your grandchildren, hug your grandchildren, and go to all the meals and things like that. Unfortunately, then you can't go back to a senior residence without, again, having a quarantine of 14 days. Because each time people shuttle between one bubble and another bubble, that's where the risk happens that you unwittingly bring something in. So I think every family has to figure out what's the best fit for their situation. And we're still waiting. 6 weeks ago, people where my mother was were completely locked down and they couldn't even go outside for walks. Right now it's better, and we're very fortunate with the nice summertime that people are getting out more. But for instance, one way to prevent infections from spreading is meals are brought to individuals' rooms rather than individuals going to dining rooms. So this is part of the new normal that Dawn was describing. Processes by which we avoid having congregate indoor meetings.
So Dawn, it is summertime. All of us looking forward to our vacations. Flights are going to begin once again to some European countries and Caribbean countries. What is your advice? Would you hop on a plane and go to a hotel?
So let me preface this by explaining to those of you that don't know me, this is the longest that I have ever avoided crossing an international border in my life by a factor of 10, if not 100. I feel like someone has tied lead weights to the bottom of my feet, and I keep getting daily phone calls from the staff at Air Canada asking me if I'm okay, because they miss me. So I very much feel the pain of those of you that are used to having a slightly larger set of horizons and now are trying to figure out how to adjust. Unfortunately, the answer is actually quite simple. This is the summer of the staycation. It's time to experience La Belle Provence. It is time to see what Quebec has to offer. And I'm going to be fairly categorical and say that I don't think it is a wise decision to travel by plane, train, or other confined indoor space activity if you can possibly avoid it. And let me give you the example of what we saw in spring break. The people who came back to Quebec with the virus in spring break in Quebec, just like the people who brought the virus to the UK, it turns out it's not because they went to northern Italy, Iran, or places that we knew there was an outbreak. It's because they went to places that 1 week later turned out to have an outbreak, and there was asymptomatic spread and shedding going on. So unless you happen to have some personal crystal ball that can tell you that 10 days from now, you will not have an outbreak in Cape Cod and that Cape Cod will be virus-free, planning your Cape Cod trip, or in my case, canceling your Cape Cod trip, is exactly what you should be thinking about doing. And then there's the simple logistics. You need to recognize that many of the destinations that we would go to, should we attempt to fly there and actually succeed in getting on a plane, avoiding coronavirus, getting off a plane, the very first thing that's going to happen is we're going to be ordered to go onto a 14-day quarantine. So your lovely trip to wherever you're going to go is going to be the inside of the hotel room at best for 14 days, or the inside of that beach house that you wanted to see. And when you return home to Canada, it is entirely likely that you will have another 14 days imposed locked in your home while your friends and neighbors are out hanging out in the park and enjoying the fact that they can have a 10-person backyard barbecue, but that you're on true blue quarantine and isolation. I'm being a little facetious, obviously, because I'm trying to make light of what is actually a very unpleasant subject for a lot of people. I think limiting travel at this stage is the wisest thing we can do until we truly see whether we're going to be seeing late second waves, where those second waves are coming, and if they're coming. And right now, we're barely out of what was a very touch and go situation here in Montreal. And I would personally ask you not to be part of the next Montreal March break that brings home coronavirus as a souvenir.
Marcel, can restaurants be part of our new normal? They reopen here in Montreal on June 22nd. Do you feel comfortable going?
Yes, I do. But of course, that's because the weather is nice. As Dawn was saying, if the restaurants were opening in January and they asked me to sit on an outdoor terrace, I wouldn't be as excited. But if a restaurant opens in June, I'm happy to sit on an outdoor terrace. I think there's ways we can space out. At a table, it would be a family member. So you're just taking the bubble from your family and going there. That's okay. I'm not as comfortable opening and crowding restaurants on the indoors. And I think we should be very careful about indoor gatherings, as Dawn has said. We should be careful about large birthday parties and weddings and all those sorts of things that can happen in restaurants. And finally, the detail about restaurants is it's one thing to have an outdoor terrace and to be served outside, but you better make sure that their washrooms are open, because a lot of the facilities, a lot of the places I've been to lately, they have them only for staff. So you may have a bad experience at the restaurant unless they at least have facilities. And those are also useful facilities, for instance, where you might want to wash your hands.
So Dawn, you spoke out publicly when Montreal was expected to reopen schools, and you spoke out against the reopening. How do you feel about the school reopening in September?
So at the time, I was very vocal about not reopening schools. We have to remember what the context was. At that point, we were still having 800 new cases a day in Montreal. There was no sign of a decrease in case numbers. Sorry, Quebec, not Montreal. No sign of a decrease in case numbers. No sign that we had turned the corner. And our hospitals were close to capacity in terms of ICU beds and hospital beds. We knew that people were afraid to come to the hospital for their critical medical care. So we were waiting for this tsunami of regular medical stuff to come to the hospital that we're seeing now. And it seemed that adding another wave to our outbreak that was first travelers, then long-term care, then healthcare workers was really perhaps not the best choice. Now we're in a very different situation. We assume, if the numbers go the way they are going, that by the time we hit the fall, that we will actually have low to no transmission. We've seen that you can reopen schools in Quebec, and what happens is you do get micro outbreaks, but we seem to have been able to manage to track and trace those micro outbreaks and keep them under control. And Trois-Rivières is a great example where we've seen 2 school outbreaks. They've been diagnosed, dealt with, contact traced, and extinguished without any major consequences. The key thing to remember with the schools is it's not so much about the children. The children themselves are at very, very low risk of any severe outcome to this disease. And I have 4 kids also, and I would be very comfortable sending them to school if they were not very large, lunky teenagers and therefore not going to school right now. It's not about the kids, it's about who the kids can potentially transmit to, the people that are in the home. So I think it's going to be very important when that happens, whether it's the daycares, the summer camps, or the back to school, that the families have to assess their personal risk. If you have elderly or high-risk individuals in the home, I don't think it's safe for you to be sending your children to those areas where there are high transmission rates. There are some mixed data suggesting kids don't transmit well, but then there are other data suggesting they do transmit well. And in Trois-Rivières, when they had the outbreak, the entire class managed to get coronavirus from kids that don't transmit the virus well. So I would say that the jury is either out or at least very conservatively doubtful of any evidence that children don't transmit this virus. Those of you that have kids and have young kids know they're really good at transmitting viruses, as you've had hundreds of colds that your little darlings have brought back to you over the years.
Yeah, and I'm an alum of the MGH daycare system here, and I think anybody who had a child in daycare would be shocked if this is the first virus on the planet that kids don't transmit.
Marcel, as part of this new normal, many of us have had hospital visits, virtual hospital visits with our physicians and specialists. Do you think this is something that's going to stay?
I think part of it is, yes. Actually, I think what COVID has done is confronted some of our longstanding beliefs about what was normal, what was not normal, whether you could have a webinar like this in your office without getting together in a recording studio. And we're starting to find that There are some things we really need to do as doctors, which is see a patient, go to the room, talk to them, examine their leg, look at their leg, put your hand on it and try to understand what exactly is going on. And there's also a lot of medical acts that we do that really didn't require that patient contact. And when you look at it from the two sides, you can say, well, from the physician point of view, I only had a few questions I wanted to know. I had lab tests I wanted to know. I needed an x-ray to review. And I can do that pretty efficiently when you are in your home and I can contact you. But there's actually the benefit to you as well, which is a lot of patients would book off an afternoon and they'd have to drive in, they'd have to pay for parking, they'd have to wait in a waiting room for the x-ray, they'd have to wait in another waiting room for the sample procurement center. What's it called? The specimen testing center here. And used to have a huge lineup. By the way, right now, if you walk by, there's a very short lineup. You can get your blood tests fast. And I think patients were often spending 3 to 4 hours of their day, once a week or once a month, to see me. And now they're getting it done in 15 minutes and they can actually go to work, or they can work from home, or they can coach their kids' homework and stuff like that. So I think there's benefits on both sides. I think what we're just trying to establish, what's the new norm that is acceptable on both sides? And how can we make sure that all our notes and our documentation and all the medical records are up to date with it when we're phoning people from our offices? But I think there's actually a lot of benefits. And I think we're going to learn that even all kinds of other meetings we used to do, that scientists would go to meetings overseas and we'd fly over somewhere for a 12-hour meeting and fly back. And now we're realizing, no, we can do a lot of these things from distance if we have the proper communication strategies.
Thank you. And as our final question today, Don, we've had a question from one of our guests about the potential mutations. Has there been an increase in potency of the virus? Can you give us an idea of what's happened already?
So there's been quite a number of genetic studies looking at sort of virus evolution. And there hasn't been a really convincing signal that this virus is a hypermutator, that it's rapidly evolving into something that causes a different disease. It's actually been a fairly boring set of studies. It's given us some profound insights, for example, into understanding how the virus got into the UK. Marcel and I were talking about this morning before the webinar. Neither of us predicted that there would be, what was it, Marcel, 1,300 different importation events that occurred. So 1,300 different people brought the virus into the UK to spread it around the UK. It wasn't 5 people, it wasn't 100 people. It was a pretty impressive number of actual importations. And so the genetic signatures helped us with that. But the fundamental changes, the supervirus evolution doesn't seem to be happening. And it's not like influenza or some other viruses where there's a lot of mutations in the proteins that we would use for vaccines. It's likely going to be an easier vaccine than influenza would be. There's not a lot of thought that we're going to have to remake this thing every year. Is it possible there will be a major mutation event? Of course, but it really hasn't come across thus far, at least not to date. And Julie, if I can add just one thing, because I have been looking at the questions, and there's one that I did want to address. There was a question about what these recent large-scale protests are likely to do to the epidemiology of the virus. And I have to admit, I've been spending a lot of time thinking about that, because you obviously don't have to look at very many of the Black Lives Matter protest pictures to recognize you have a lot of people in one place, and that should be a recipe for transmission. I guess the pro, if you will, is that a lot of these people are indeed wearing masks, and it's an outdoor event, and you're not standing next to the same person at the same time for 15 minutes. All of those factors suggest that it should be actually pretty reasonable. The one that worries me was highlighted in the paper this morning, however, and that is the use of chemical irritants and tear gas. And that is the one thing that I think might actually change a little bit, because you can imagine those are all designed to increase coughing, sneezing, spitting, tears, and secretions. People who've been involved in those events, I think if there was somebody that was virally positive, we might have created a super spreader that way. If I was to design in my head in a horrific way to make somebody into a super spreader, the only thing I could do more than that would be to lock them into an enclosed space. So I'm optimistic that by and large, we won't see massive effects, but I'm a little concerned about those particular single exposures, if you will.
Dr. Don Sheppard, Dr. Marcel Behr, thank you so much for joining us today. And thank you to our guests. We hope that you have found this webinar to be informative, and we also hope that you'll be joining us next Wednesday at 1 p.m. for our second webinar with Dr. Bruce Mazer and Dr. Matthew Chang. So thank you so much. Have a wonderful afternoon.
Thank you, Julie.
Thank you.
Bye-bye.
Have a great day, everyone.